We have to have them.
Yes,
Okay. Recording in
Caption.
progress.
Yep, we're good. Thank you.
captions would be nice.
Captions would be nice. Here we go. Show captions. English.
Perfect. Good morning, everyone. Committee members, again, if you wouldn't mind putting a CM either in front of your name or in back, that would be awesome. That helps me identify you when we're calling and doing roll. Once again, thank you everyone for joining us this morning for our Healthcare Workforce Committee for September 6th. We're going to go ahead and excuse me, start with introductions of committee members, and I will go down the list and call you. My name is Laura McKean. I'm the chair of the Healthcare Workforce Committee. I also serve as the Senior Director of Oral Health Services and Community Engagement for All Care CCO. And I am going to invite my co-chair, Paul Gorman, if he would introduce himself.
Morning, everybody. My name's Paul Gorman. I'm the vice chair of this committee, and I'm recently retired from Oregon Health Science University, where I was a professor of medicine.
And Paul, how long were you at OHSU?
Since 1990.
Well,
Whatever.
happy retirement.
Whatever the math is.
Happy retirement, Paul.
Thank you.
How about Judy?
Sorry, it took a minute to find the unmute button. Phew. Judy Geiger, Vice President of Patient Care Services at Columbia Memorial in Astoria. And I've been there for almost 5 years and on this committee just this year.
Thank you, Judy. Glad to have you. Larissa. Can you hear us, Larissa? If you're talking or on mute, I always like to say that.
There we go. Sorry.
You're fine.
So Larissa Mejia Medina, I work at Road Community Health as the Quality Improvement Nurse Director. And I've been at Road Community Health for 10 years and a new member to the committee as well.
Thank you, Larissa. Aaron.
Good morning. My name is Aaron Hines. I'm the Chief Executive Officer at Yellowhawk Tribal Health Center out here in Eastern Oregon.
Thanks, Aaron. Elena.
Good morning. My name is Elena Shabloski. I use she, her pronouns. I am a dentist and dental director at La Clinica, which is a federally qualified health center in Medford.
Thank you, Elena. Alicia.
Hi, everyone. I'm Alicia Jackson. I'm a family medicine physician and medical director and associate program director over at the OHSU Health Hillsborough Medical Center residency program.
Thank you, Alicia. Daniel.
Good morning, everyone. I'm Daniel Ornella.
Daniel,
Sorry
we
about
lost.
that.
That's okay.
Yeah, something happened there. My name is Daniel Ornelas. I'm a committee member, and I also serve as a dental program manager at the Virginia Garcia Memorial Health Center.
Thank you, Daniel.
Thank you.
Bhavesh.
Yeah, hi, good morning. I'm Bhavesh Rajani. I'm an associate medical director at Pacific Source. I have a background in family practice.
Thank you. Ian.
I'm Ian Strauss. I use he, him pronouns. I am the Special Projects Coordinator at Whitebird Clinic, a federally qualified health center in Eugene, Oregon.
Thank you. And I didn't see Dr. Hemmings on. I'm scrolling through, Mark, but did I miss Dr. Hemmings?
So on her way, there were some technical glitches, and she just emailed me, so I expect we'll see her momentarily.
Okay. And before I go to Brenda, did I miss any committee members?
Me.
Oh, Aubrey, sorry about that.
That's
Thank
okay.
you.
Good morning, Aubrey Corbett. I'm a primary care physician, naturopathic doctor with Central City Concern and FQHC in Portland, and I am a committee member.
Thank you, Aubrey. And Brenda Johnson.
Hi, I'm Brenda Johnson. I serve as your liaison from the Oregon Health Policy Board. In my daytime job, I serve as the CEO of La Clinica in Medford, and I use she, her pronouns. Good to be with you all.
Thank you, Brenda. And I think we've got everybody, Mark.
I think we do also. Yes, when Dr. Hemmings is here, she can be introduced. And also Manu will be phoning in, so it may be a little while before we have him, but he will be here as well.
Okay, thank you so much. And Jessica, can you go to the next slide, please?
I'm attempting to do so momentarily. Let's see if it will let me. Oh, hopefully I didn't go too far.
That's okay. As you can see here, we are recording the meeting. This is a public meeting. Committee members, if you're able, if you could turn on your camera so we can see your lovely face, that would be great. If you can't, due to bandwidth issues, we totally understand. And also it says their live transcription is available. And next slide, Jessica.
It doesn't want to cooperate. One moment. There it is.
All right, and we have already done that. Go to the next slide. Okay, here you can see our agenda for today. We have a pretty packed meeting with a lot of updates. I'm looking forward to hearing from our subcommittees and all the activity that they've done so far. And then you can see we'll have a discussion on the equitable health professional shortage designations, and also some discussion around the healthcare provider incentive fund. So if you can go to the next slide. We've already done that. And we've already done that. I guess I should go through the slides before I go do introductions. Here are a list of some OHA staff that are attending today. Again, there could be some folks that we have missed that are on this list. So I appreciate you putting your name and pronouns and organization, which part of OHA you're with. So thank you for doing that. And next slide, Jessica. Okay, we'll take a quick review of our health equity framework. Go ahead and go to the next slide. Always like to talk about the definition of health equity that we have from OHA and the Oregon Health Policy Board. I like to read it. It's a good reminder rather than just seeing it on the screen. And we appreciate this definition. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. And we believe that achieving health equity requires the ongoing collaboration of all regions and sectors around the state, including tribal governments. And with this, we will hope to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So next slide. Okay, before we go on, Dr. Hemmings, I think you did join us. If you wouldn't mind just doing a quick introduction, that would be great.
Dr. Rosemary Hemmings, she, her pronouns. And what else? I missed it because I had tech issues.
Oh, that's it. You're good. We just wanted to recognize that you were here.
Thank you.
Absolutely. So a quick summary of what we learned when we did the 2021 listening sessions. You can see here we had 7 main themes that came out of those listening sessions. Address the leaky pipeline and develop career pathways, confront bias in education, training, credentialing, establish inclusive recruitment, hiring, or retention, tackle compensation issues, which always seems to be a big one, create culturally responsive services and practice environments, restructure provider incentives, which I think we're going to learn a little bit about, and address other issues related to health equity. Next slide, Jessica. Can you go back one? Perfect, thank you. So these are some of the guiding questions that we used for our equity framework. You can see them all there. I don't think I'll read them all, but they are in the packet. But I do think they're really important to remember, as opposed to not opposed. I think these are important to remember in addition to the health equity definition that we have, because they really go together. So thank you, Jessica. And next slide, please. Okay, I went through the July meeting summary. I'm hoping everyone else had a chance to review it. Are there any additions, corrections, changes to the July meeting summary that was sent out for you to review? Any committee members have any comments? Okay. Can I get a motion from a committee member to approve the July meeting summary?
So moved.
Thanks, Elena. Can I have a second?
I second.
I second. Sorry.
That's okay. Thank you. I think, was that Daniel? I know I heard.
Correct.
I believe Dr. Chowdhury has joined
Chowdhury.
and also Coy.
Okay, perfect. Okay.
I joined by phone.
Perfect. Okay. Coy, if you wouldn't mind taking a minute and introducing yourself, just name, organization, pronouns, if you would like.
Yeah, thank you for the opportunity. Oh, sorry, go ahead. I'm so sorry. Were you asking me
No,
to?
go ahead, please. Go ahead, please.
Oh, yeah, sorry I joined late, everyone. My name is Dr. Manu Chowdhury, and I serve as president of Capital Dental Care. And in addition to serving on this committee as a committee member, I also serve on HITALK, which is the Health IT Oversight Council, as well as the Metrics and Scoring Committee. Thank you for having me here.
Thank you, Dr. Chowdhury. And Coy?
Yes, hi everyone. My name is Coy Vu, pronouns she, her, hers. I'm the executive director of the Coalition of Community Health Clinics.
Thank you, Coy. All right, moving on. Next slide, Jessica. Thank you. We do have a few minutes set aside for public comment. I don't know if we have any public comment, Jessica or Mark, either submitted. I didn't see anything submitted. I don't know if there's anyone on the call today that would like to give public comment. Kimberly, I'll get to you just one second. I see you have your hand up. Is there anyone else besides Kimberly that might have public comment? I can't see everyone, Jessica and Mark, so you'll have to help me a little bit.
Or we, as far as I know, did not hear from anyone else. We did know that Ms. Lindsay wanted to provide some comment to the committee.
Okay, we'll start with Kimberly. And while I just want to tell you all, we very much appreciate the public comment that you are about to share with us. We take it very seriously and take it into consideration. You might not hear some comments back from us today, but we do acknowledge your public comment and we'll discuss it and take it to consideration. So Kimberly, if you want to go ahead and take maybe 3 to 4 minutes for your public comment, that would be great.
Great, thank you. Can you hear me?
We can.
Great. So Thank you for allowing me to share a few thoughts this morning with all of you. I appreciate it. I appreciate all of the work that you are doing in the field of healthcare. I recently have encountered some additional challenges related to workforce and was thinking that this might be a good opportunity to share those. You know, I think that healthcare was, as we all know, particularly impacted by COVID, and the workforce issues are a little bit more pronounced. And we're still climbing out of COVID and a lot of the fallout that happened to that. I mentioned earlier that recently we've been a little bit more impacted. You know, I didn't really track prior to this year how it worked in Oregon for people who were transferring licenses, both on the nursing side as well as the LCSW LPC. I'm sure that you're familiar with the reciprocity term. Recently, as we have been trying to be creative with hiring and get some of our positions filled, I have learned that it's taking quite a long time for people to get transferred. Learned that Oregon is not a state that has reciprocity agreements in place. Most recently, we had an NHSC scholar who moved here from another state to one of our NHSC sites, at NHSC approved sites. They had been attempting for several months to get their license transferred without success, and were considering moving back because they were looking at a payback through the NHSC loan repayment program. Looking at a payback because their license wasn't able to get transferred timely. So I guess I just wanted to say that I really encourage this group and anybody who's on the licensing board or working with licensing boards or has any ability to move things a little bit. I'm sure it's a complicated issue, but Oregon likes to be on the cutting edge, and I'm really struggling with why we are not agreeing or entering into reciprocity agreements. I also want to come with a couple of suggestions or solutions. If we're not able to do reciprocity, maybe there's some hiring things that can be done to speed up the hiring things, meaning maybe the boards could hire additional staff to speed up the licensing transfer process, especially so that us in rural areas are not hampered. Or again, if something like reciprocity could happen, I do want to give a shout out to Mark. He has been helpful and on a case-by-case basis with helping things move along. And there have been some shortcuts that have been taken by the different boards, but some of those shortcuts don't meet federal requirements for NHSC. So just because they work in Oregon, it still is hampering us. Anyways, I think that that's about all I wanted to say. I wrote some notes and then I left them back at the office and traveled to Condon. So just thank you for listening, for taking my public comment, and I'm hopeful that there's some better solutions that can be reached, especially for those of us in rural areas who are really struggling to fill positions.
Kimberly, thank you for that. Can you, I don't, if you did, I missed it, but could you just tell us what your role is and your organization?
I'm the Executive Director of Community Counseling Solutions. We are a community mental health program serving 4 counties in Eastern Oregon.
Thank you.
5 counties in Eastern Oregon, sorry.
And if one more thing, if you are able, if you could put your contact information in the chat, that would be great. If not, Mark, I'm sure you have it, just so we can reach out. But
I will do it right now.
Thank you so much for your public comment, Kimberly.
Yep.
And is there, I know Victor might have some public comment. Was there anyone else besides Victor? No? Okay. And Kim, your hand is still raised, just so you know. Sometimes it's hard to
got it.
remember to put your hand down.
I'll do it in a second.
That's okay. Victor, did you have some public comment today? And if you wouldn't mind introducing yourself and no?
No, thank you. I'm not prepared.
Okay, all right. Well, is there anyone else that has any public comments? Don't see any hands, don't hear anything. All right, perfect. We'll go ahead and move on. Next slide, please, Jessica. Okay, now we are going to hear from our wonderful liaison, Brenda, to give us some updates on the Oregon Health Policy Board, and then we'll get a couple of OHA updates. So Brenda, I will turn it over to you.
Great. Thank you so much, Laura. And again, it's just great to be with you all. I think what I have for you today is just a preview of things yet to come. So beginning, let's say, I think on October 4th, we have a board retreat planned for us in Bend, and part of that agenda includes welcoming 2 new board members, which I'm excited. I think it's still premature to announce who those individuals are, but once that's more public, we'll be able to welcome and onboard 2 new members to the board, which we're excited about. The board is contemplating in this agenda for our retreat several things, mostly of which will be discussions about the board's priorities for the incoming year. We've submitted a letter to Governor Kotek outlining areas of strategic importance from our perspectives as a board, and they include the continuous support for the agency as it recruits leadership for the agency, to continue our pursuit in areas of health equity, and some specific ideas about how to move that agenda further faster. Work in behavioral health is another area that we've submitted for the governor's consideration that we prioritize, along with implementation of the 1115 waiver. And last, but certainly not least, continuing our focus on healthcare model improvements that include efforts, upcoming efforts in the next several years around CCO procurement work. So it's a pretty packed agenda to be thinking about all of those really meaty topics and what it means to focus our effort in that, in those areas of strategic importance for the board. The process often between the governor's office and the board includes governor helping us set priorities and exchanging where we think those priorities are. And so that's the process that we're in right now. That's all I have for you. Happy to give an update after the retreat, at this committee's next meeting. And I don't know, Laura, if you want to spend any time, that I'd be happy to answer any questions about where we stand or anything I've said so far. Yeah.
Sure. Thanks, Brenda. Committee members, any updates? Comments, questions? I will encourage everyone, if you can. I got through, that was a long meeting, Brenda, your last one. It was like almost 4.5 hours, and it was held in Hood River. So the policy board is starting to do some different areas for their meetings now, a hybrid model. So that was a long meeting, and I've gotten through like 3.5 hours of it. But I would encourage anyone, if you can't attend the meeting by Zoom during the meeting, the recording is also posted on the Oregon Health Policy Board website. And I would encourage everyone to listen to the recordings, view the recordings, because the last one was really great information from different partners around the Hood River area. And I commented to Brenda, I think it was you, Brenda, about how dental access came to it was really prominent. And that's a lot of the world that I live in is dental and access. And I was surprised to hear that it was that much of an issue there. I didn't think it was. And it just goes to show you that I I'm not in my own little bubble down here in Southern Oregon, that this is a problem everywhere. But again, I encourage committee members, if you can, to listen to those recordings or view the meetings when they're happening, because it's really good information. As far as the OHA updates, those updates were provided to you, committee members, in writing as a document with your packet. So because we wanted to leave enough time for our subcommittee work this morning. So you should have those in your packets. If anyone has any questions about the updates that were provided to you, now is the time. If you want to provide comment or questions about the updates, feel free right now to do that. And if not, we'll go ahead and move on. I don't see any hands up, Mark, do you? And if there's none, that's great. Okay. All right. Now we will talk about our subcommittees, and we're going to have a discussion with our committees. I sent a little email out this morning just to the committee chairs, just thanking them for all the hard work that they have done with this. And Mark and your team, I appreciate all the support that you have given these subcommittees as well. So we'll go ahead and dive in. Jessica, if you could go to the next slide. Okay, I wanted to remind everyone, this is our strategic framework that we came up with as a workforce committee. You can see there, I love the Venn diagram. I say that every time we meet, I think, because we have these 3 bubbles, but really they all intersect. And so even though we're working on these strategies separately, they really have an intersection. And I really think it's important to just look at the vision, because that's really where we're at. We want a robust, diverse, and resilient healthcare workforce that provides culturally and linguistically responsive care, something that eliminates health inequities and meets the local healthcare needs of everyone here in Oregon. So you should have that. I encourage everyone to review it as much as you can and remember why we're doing the work that we're doing. And next slide. Okay, so we are going to start with the Wellness and Resilience Subcommittee. So we will turn it over to them.
All right, I think them is me.
Thank you, Alina.
Yeah. So I've had the opportunity to chair our Wellness and Resilience Subcommittee for the last few months. And we've had a good crew of Bhavesh and Manu and Larissa, and then Aubrey and Bob have been able to contribute via email. And then Laura and Paul have popped into a couple meetings as well. So we can go to the next slide. I'm excited to share where we're at with y'all. Great. So this is the slide that we've all seen before, so we can kind of skip quickly through this, since Laura gave us a great orientation to our definition of health equity that we're using to inform the work that we do. So we can go to the next slide here. And then we've seen these before, so we can kind of skip through this real quick. And then these are our guiding questions. Again, Laura oriented us to these really nicely, so we can skip through here. All right, so this is, we were given these slide templates by Mark. Thank you, Mark. And for those of you that have served on the subcommittees, these headings will be familiar, because these are the headings that will eventually make up the white paper that we put together. And so I love a direction. I love a format. And so I've followed these pretty closely, and we'll just go section by section and give an update of where we're at with each of these updates, or each of these sections in the future white paper. The first section in the paper will be the last section that is written. And so that's the executive summary. And so our intent is to write the executive summary after all of our other sections are complete. And one thing that came up in our conversations as a subcommittee is, and I have a hunch that maybe this has come up in other subcommittees as well, is that while we talk about wellness and resilience in the healthcare workforce, and while there are certainly unique components to wellness and what that looks like in a healthcare setting, a lot of the components, a lot of the factors can apply to other sectors as well. So while our focus is really on healthcare, we do want to make a note in the executive summary and in a couple of other places throughout our report that we welcome other professional leaders, employers and policymakers in other sectors to read this report and collaborate with us, and maybe take some of the work that we've done in thinking about wellness and resilience and apply that to their sectors as well in whatever way they see fit. So that we foresee being part of the executive summary. The next slide, please. All right, actually, let's go back to the current policy approach. I think we skipped over. Yeah, there we go. And so this will be where we start. The overview has two sections: our current policy approach, and then the vision that we have for a future in wellness and resilience in the Oregon healthcare workforce. And Mark and his team has been very helpful in helping us put together what our current policy approach is. And as Mark and I were having a more candid conversation, I said, it basically sounds like we think wellness is really important. We've done some piecemeal pilot projects and data collection, but we haven't really done something that feels thorough or complete enough to put together a cohesive policy. Is that right? He said, yeah, pretty much. So that's the informal summary of our current policy approach. Some more formal statistics for those of you that like the numbers you can see on your screen here. We certainly know that burnout is responsible for clinicians and all of our healthcare workforce leaving the workplace. We have better data for clinicians in particular. And so we see 54% of nurses and physicians are experiencing burnout. 60% of medical students and residents are experiencing burnout. And in Oregon specifically, like I mentioned, there has been a lot of discussion and some pilot efforts. Probably the primary pilot project that has been, in my estimation and the subcommittee's estimation, a great success has been the Oregon Wellness Program. And that was even expanded further this year to include nurses and dental hygienists, which I was really excited to hear. And then there are also some federal efforts to identify problems and address them. Examples are this SAMHSA report, the HRSA requirements for incentive, or HRSA also now requires their FQHC participants and NHSC participants to answer some questions about wellness and what they're doing to support their staff wellness. And then Mark also mentioned that at our site visits to FQHCs and NHSC participants, he and his team always is sure to ask questions about wellness and burnout and resilience. The OHA itself has had limited activity. So right now there's no CCO requirement. There's no metric related to wellness or resilience. And there's no specific data collected on burnout as part of our licensing renewal or anything like that. A timely update is that this year House Bill 2235 was passed, and that specifically asks to create a work group focused on administrative burden in behavioral health. And so we reference that in our report as well. All right, next slide. I should say, there's I think 3 more slides. I'm gonna get through those, and then I would love your we would love your feedback and comment and questions. I think that the arc of this paper sort of blends together, and hopefully questions will be answered as I go through each slide. So I'll make time for questions at the end. And Victor, I see your comment there. I'll be sure to read that when I'm done chatting. We'll make a note of that as well. Okay, so our overview, the next section of our overview is a vision. So what we want to create. The past policy is what's happened so far, and this is what we want to create. And something that our subcommittee really came back to over and over, and I give Manu a lot of credit for this, is that we're never going to eliminate all of the stress in healthcare or in work. Our hope is that we might be able to identify some key pinch points and remove those from, or a create systems to help reduce the burden of those. And healthcare is a stressful career, a stressful place to be. We get the vast privilege of caring for others, and that comes with a lot of tough stuff too. And so we really see a vision of wellness where we give our workforce the tools to change their relationship to stress. And so we want kind of this top down and bottom up approach. We want to identify those main pinch points and work on addressing those. And we also want to give individuals the tools to have something stressful happen to them at work and stay grounded and centered and know what resources and tools they have available to them to take care of themselves through that stressful work. The next bullet point here is that this is maybe for my own wellness. We're not trying to fix burnout with this 4 to 6 page report. That's not going to happen in 6 pages. And it's not going to happen in the next year. And so our orientation throughout this work has been, what is the next right step? What is one actionable, one or a few actionable things that OHA and the state of Oregon can take to get closer to that vision of a well and resilient workforce? And the final bullet point here is that we don't think that there is a one-size-fits-all approach to wellness. And so you'll see in our recommendations on the next slide that we want to lean into giving organizations and individuals the tools to address specific issues that are causing burnout for their employee. We wanted to stay away from a state level fix and instead make the opportunity for individual workplaces and individual workforce members to identify what they need. So here on the next slide are our 3 recommendations. And so we decided to focus on just 3 recommendations. They are somewhat broad recommendations, and there's some additional specificity in the report itself, which I am happy to share with anyone or share my screen and bring up right now. But we focused on these 3 recommendations because we wanted the report to feel actionable and concise instead of overwhelming. We wanted OHA or policymakers or employers to look at this and pick 1 or pick 3 and not be overwhelmed by a list of 25 best practices or recommendations. So you'll see on the screen the 3 recommendations that we've landed on. The first is that we want OHA to collect data on workforce wellness and then create a task force to review the findings and make further recommendations for systems and policy change based on the findings. And so this is when I'm going to pull up the draft here, just for my own notes. The details of what we would recommend that data collection look like would be to do some sort of collection process across all health professions across the state, and for that to be based on a evidence-based or vetted instrument. And some examples that we were able to find in our research were the Empowerment at Work Scale, the Maslach Burnout Inventory, and the Wellbeing Index made by the Mayo Clinic. And then we would also want a secondary component of that survey to ask specifically about what the main pain points contributing to burnout are. So some examples of that might be work schedule, electronic health record, payer-related paperwork, so like referrals and pre-authorizations, productivity targets, senior leaders, vacation policies, social connection with colleagues, compensation models, opportunities for professional development, etc. And so that survey would really be two components. How well are you? How burnt out are you? And what is contributing to that burnout? And then that data would be delivered to a task force, which we recommend is made up of about 8 to 10 members. We recommend that 2 to 3 of those members be current healthcare workforce committee members, so chosen from this group that have experience or expertise in wellness and workforce. We would also want at least one representative from a rural community, at least one representative with experience caring for populations with intellectual or developmental disabilities. We would want professional representation, so at least one of those representatives being from medicine, nursing, dentistry, behavioral health, and traditional healthcare workers. And then through our research, we discovered that some larger organizations have what's called a chief wellness officer. And so we thought our recommendation would be to include someone in that role, whether that is within Oregon or from another state with experience implementing wellness programs in a healthcare setting. And so we would want the task force to then review the data that was created and make recommendations for systems and policy change based on that. So that's our first recommendation. That's probably the beefiest recommendation of the 3. It also goes back directly to our original purpose, which was to one of the intents of the wellness and resilience Venn diagram was to collect data. And so this speaks directly to that. The second recommendation here is to expand and fund the Oregon Wellness Program to become a one-stop destination for wellness resources for all healthcare workforce members in Oregon. We love the work that the Oregon Wellness Program is doing right now. And we imagine that it could become a broader resource to include things like, we're a bunch of healthcare workers, so we thought about prevention, acute intervention, and chronic management. And we think that what the Oregon Wellness Program is doing right now is really great for more chronic management. That is supporting one-on-one therapy sessions for healthcare workers with a licensed and qualified counselor or therapist. We would love to see that expanded out to also include prevention resources. So we imagine that being like short videos about how to find a moment of calm throughout your day, how to set boundaries, how to care for yourself, how to be well and resilient. And that we would love for those videos to be incorporated into healthcare curricula across the state and students be given credit for watching those. And for employers, we would love for employers to incorporate paid time for their employees to watch those videos throughout their work schedule. We also would recommend that the task force from step 1, from recommendation 1, give some insight onto what would be the best resources to make available to healthcare workers. And we really would want that to be free and available to all healthcare workforce members in Oregon. So that would be the prevention side. The chronic management is already happening, so continuing to expand that out to all healthcare workforce members in Oregon. And then the acute intervention would be a resource, a directory of things like crisis lines that would support our workforce members in crisis. The third and final recommendation, and this is the last main slide here, is to create a statewide system to recognize and reward employers that take steps to understand the needs of their employees and implement wellness programs that address those needs. And so this was really modeled after thinking about the Oregon Business Journal's 100 Best Businesses to Work For, or the like NCQA's accreditation work, the idea that we could have a stamp or a accreditation for healthcare employers in Oregon that are listening to their employees and taking action in response to that. And so real quickly, this recommendation would call for the creation of a rubric to address that. And I think in our recommendation, we say that either OHA staff could take that on or an appropriate designee of OHA staff. So if they decide that a task force would be best in charge of that, that would be appropriate as well. And this gets to that, my comment earlier, that every workforce, every culture, every setting is different. And so we really want to encourage employers to be listening to their employees and learning what employees want for their own wellness, and then taking actions to work towards an agreement where those desires can be met or met partially. All right. That was a lot of words. We'll go to the next slide real quick. These are our resources that we've used to inform our work. And I think these were also sent out with the agenda. Yep. And so if you want to dig into these as well, feel free to. They have all been very helpful in our learning and growing. All right. What do you think? What did we miss? What did we get wrong? What do we need to do more of? What are we copying from work that you're doing? I'd love to hear your thoughts.
Jessica, could you go back to the recommendation slide?
Thanks, Laura.
Perfect. Okay, I just have a couple questions, Elena. I didn't know a lot about the Oregon Wellness Program, but while you were talking, I was just looking a little bit. Do you know if the services that they provide, it's not for just a person that's in crisis with their burnout and frustration? It's, maybe let's word this off before you get to that point. Is it what type of folks utilize that program?
So there is on that resources page, there's the Oregon Wellness Program is fairly new. It was started in 2018. Okay. So there's not a lot of really good data. They've started to research who exactly is utilizing that. I've been quite open with the fact that I've utilized it. So I can say from personal experience that no, it's not for immediate crisis. It's for if I'm experiencing burnout or I'm thinking that I might start to experience burnout. It's similar to an employee assistance program in that regard, that if there's, it's very much individual oriented. So you can go to the Oregon Wellness Program webpage and be directed to a directory of providers. And they provide both in-person and telehealth services. And then the Oregon Wellness Program pays for 8 confidential sessions per year. If you want to continue on past those 8 with the provider, then that would either be through insurance or out of pocket. And right now it's available to nurses and NPs, physicians and PAs, and dentists and dental hygienists.
And dental therapists, I saw was listed.
And dental therapists, yes. Yeah. So basically licensed people that are licensed by the Oregon Medical Board or the Oregon Dental Board.
Okay. I'm wondering, so that's awesome. The other thing I wanted to mention was, it seems like, all the metrics and measures that CCOs are held accountable for, I think it's 15 for next year. Dr. Chaudhry, correct me if I'm wrong, because I know you sit on the committee. But it seems, and I know you have to, it has to be tied to data and encounters, but I'm just wondering if we could, next time around, when we talk about the metrics and measures for the CCOs, I'm wondering if there's a way to weave something like this in, maybe in the challenge pool dollars, which are like extra dollars. But I'm wondering if there's a way to weave something like this in, so, it's not necessarily tied to numbers, which is what we're tied, it's just tied to numbers all the time, it seems like, in data. But I'm wondering that, and so I made some notes, and I'm wondering if there's a way when we start talking about that next year, because the burnout is so widespread throughout the state. I'm just wondering, you know, if there's something we can do about that. So I'm going to ask about that. Okay, so
that definitely came up in our conversations, the idea of adding in a metric of wellness. I think we all just decided that we would need a baseline first. And so that's where that data collection comes in. And that certainly that the task force that would form to review that data, we would ask that one of the considerations be if we think there should be a metric and what that would look like. I think we think that we don't have the expertise on the subcommittee right now. And frankly, there's not the data in Oregon to know what an appropriate or effective metric would be like yet. And it's certainly on our radar.
It would be something great to talk about.
Yeah, I agree. Yeah.
Okay. Paul, I see you have your hand up.
I do. I want to commend that group for, first of all, reducing things down to 3. As you'll see from my subcommittee, we are very far from getting down to 3 recommendations, and I think there's great wisdom in what they've done, and I hope we can do similar. And the other thing I want to commend them for, and I think it's crucial, is that these recommendations both address this issue at the individual level and at the system level. And I think I think I've said this in meetings before, if all the workers are getting hurt, then taking care of them is important, but changing the work so that they don't get hurt is equally important. And I think this set of recommendations, including number 3, so there's wellness for individuals, but there's also how do we recognize and reward or incentivize systems to make their work not burn people out. I think that's great, and I like to see that included in the recommendations.
Thanks. Yeah, that was our hope. That was our hope, to address, kind of come at it from different angles. So thanks for that, Paul. Yeah, Judy.
Hey, I'm just wondering, do you have a ranking for these 3 recommendations, or do they come as a package deal for OHA? Like, could they decide to do 1 and not 2 and 3, or does that make sense?
Yes, we talked about ranking the recommendations and decided against that, partially because, like what Paul said, that they each to us speak to kind of a different approach. Certainly, OHA would be welcome to pick one that seems most feasible, or not pick one. We think there would be value in picking certainly all 3 of them or one of them individually. So we don't think there's one that's most important on this list.
Thank you. I think they look great.
Thanks. Do you think there's one that's most important?
I don't. I actually think I agree with you that they hit on different issues. So I like all 3 of them.
Thanks. Coy.
Hi there. Thank you for this really detailed presentation and the information that's provided. I'm just curious to see if there were consideration in regards to workers of color in the workforce, you know, in both regards, in regard to recommendation 1 and 2, as far as collecting data that is specifically tailored to workers of color within the healthcare workforce, the potentially level of discrimination or even bias that they may experience in the workforce and or experienced by their patients. And then also with the expansion of the Oregon Wellness Program, I'm not too familiar of that program, but you know, just thinking about EAP programs, I know that our staff and even my own experience calling those numbers, there are not often folks that reflect the communities that we serve, or even my personal experiences. And so it's oftentimes not necessarily helpful. It is helpful, and it's not necessarily what the care that we need at the immediate time, based on, you know, some of the experiences that the employees may experience.
Thanks. I certainly thank you for that. The quick answer is that was part of our conversation, and you're right that's a gap in our recommendations as they stand right now. So a couple of quick thoughts that came to my mind is certainly, and let me know if this feels satisfactory, or certainly I'd be happy to chat with you one-on-one to make sure that we're capturing your questions here. On the data collection, so am I hearing you say that it would be good to include specific questions about workplace harassment and discrimination from both colleagues and patients?
I think potentially questions regarding harassment may not be needed in there, but, you know, going into more detail as far as, you know, their diversity, their even, I would say, you know, what communities they identify with, even if it's part of the, you know, for instance, part of the LGBT community. And then having questions in regards to that would tailor more towards maybe support that they may have or lack of support within the workforce itself. I know in a legal standpoint, we probably don't want to ask questions in regards to harassment in a survey. And so that's more tailored specifically for you know, organizations or clinics or you know, entities themselves to kind of do that investigation separately.
And when you say support, what kind of support are you imagining, or how would a question be structured?
Yeah, I'm not too sure at the moment, but I think that there, you know, through conversations, I think we'll be able to kind of figure that out. I don't know if you all have those questions already tailored and written out, but I think that having some intentionality around those questions specifically for folks of color will be important.
Great. We don't have them written out. I think that was certainly a sort of to be developed in collaboration with OHA. We had some general themes of the questions. I think certainly we would want to collect REAL-D and SOGI data to the statistical word is escaping me right now, but to make sure that we can look at any discrepancies and inequities between white workers report a 20% burnout rate and workers of color report a 45% burnout rate. Whoa, okay, how are we going to specifically address that? So I think that would be one simple and obvious step to take in that regard. And then, yeah, I think certainly we could work into our recommendations asking about support specifically related to identity-based burnout. I think that we could incorporate that. And if a specific wording or specific type of question comes to mind as you sit with that, please let me know. We'd be happy to include that. And then to your question about the Oregon Wellness Plan, I think that's a great point. The providers on the Oregon Wellness Plan have been vetted to have experience working specifically with healthcare workers and in situations related to healthcare burnout. And I will certainly add to our recommendations that we evaluate the availability of providers that would match with, or that we have a variety of identities available, so that if someone wanted to speak with a provider, speak with a therapist that aligned more closely with their identity, that they would have that option. So thanks. We'll add that to the evaluation of the Oregon Wellness Plan to look at the diversity of the available providers.
Yeah, and we know that that's a national issue.
Yeah, exactly.
But you know, again, the intentionality and just adding some language around that, you know, will help enhance some of the work that you all are doing, I hope. So.
Yeah, thank you so much. I appreciate it. Yeah, Laura.
Unmute. I have one more question for you, Elena. Is there any, I know this is, it's licensed providers, right? In the state of Oregon. Is there any possibility of expanding that? And dental assistants come to mind only because I have, you know, we know the strain and the stress that these dental assistants are under because of the workforce shortage. Is there any plan or way that this could be extended to a certified, or is it just keeping it toward the licensed providers?
we
The
would-
Oregon
we would-
Wellness Program.
We would like it to be available to all healthcare workers in Oregon. We would
Okay.
like to take away right now, so yes, dental assistants and medical assistants and traditional health workers and our patient services representatives and receptionists and our call center employees and everyone that supports healthcare in Oregon. Because we know that they all feel the stress and burnout of the healthcare professions. The Oregon Wellness Program was originally created through the funding stream of the Oregon Medical Board and has kind of grown out from there, has gotten funding through the Oregon Dental Board as well. There's been support from the medical and dental and nursing associations, from a couple of private organizations as well. And so part of our call is to remove the funding from the boards and to instead make it a separate budget item that would be available, to make it available to all healthcare workforce members. There was some movement towards that. Oregon Wellness Program got some legislative funding this year. And so there's a positive trend towards that being a possibility in the future.
Okay, thank you. And I didn't mean to diminish the importance of the other work.
Oh, no, I know.
By any means.
I know.
Okay, so we'll go ahead and move on. If anyone has any more questions, you can contact Elena or attend the next meeting of her subcommittee. And we are going to move on to Paul Gorman and his subcommittee presentation. Paul, I hope you knew you were going next.
I did not, but the next set of slides is the diversity group.
Yep, we'll have
So-
to,
You want to skip ahead?
yep.
Okay. There we go. Okay. So we are the Workforce Development and Retention Subcommittee. And we've been working hard, but we haven't got as much done as Elena and her group have. But let me tell you what we've been doing. And I'm not going to follow the OHA report format so much as simply say, here's what we did and here's where we are. And here's where we hope to get to. So next slide, please. Just a reminder, we don't need to go over all this again, but I was thinking as Elena was speaking, as Laura before, it's, I think, critical that I really think this, the Venn diagram, the vision and the mission are, put a lot of effort into these, and I really think they need to stay front and center so that when someone looks at a report, they don't lose sight of this big vision, because I think it's critical, and so I want to always have it be there. Next slide, please. There. So I'm going to tell you what we've done so far. And the first thing we did in our group was brainstorming. We asked everyone on the subcommittee to contribute ideas, programs they've heard of that are successful, thoughts or other kinds of ideas they thought might be useful. What are the things that we can do to improve the growth and retention of healthcare workers in the state? We had a brainstorming session and everybody contributed to a Google document. And we got about 21 different suggestions. And here's some examples. I'm not going to go through all of them here. There's not time. But for example, one suggestion was for a first-time home buyers type of program. This is a program where somehow healthcare professionals who are moving, just starting out, and with all the other stuff they have to deal with, can we help them buy their home? With some kind of lower mortgage rate or down payment assistance or something like that. First time home buyers type of program. Another suggestion was, how can we collaborate with local educational institutions on scholarships, internships, and outreach to interested community members? And I think the sense of this was very much local. So local communities, local institutions try to develop and collaborate in ways that will increase the opportunity and the interest that potential healthcare professionals might have. Another suggestion was that we have cultural competency training requirements for certain healthcare professions or workers, but not for all of them. And it would be helpful to have this training and funding be available for that training at basically all levels. This gets back a little bit to a conversation we just had. There's so many programs where we're talking about the program for one particular type of health professional, but in most cases, I think we're generalizing to everybody that's helping take care of our patients, from licensed to certified to unlicensed traditional health workers, the whole spectrum. Because we can't, it's a team, and we all know that it's teams that take care of our patients and our clients, and we need to have a team approach to supporting the workforce at every level. Another example was how do we find examples of barriers that might exist within job descriptions that might prevent people from even applying for healthcare positions? So what are the things that we inadvertently are doing or saying in our job descriptions and otherwise that limit that keep people from seeing that the job might well be for them? And another example was several models like those of the Northwest Native American Center of Excellence. There are several models where they have a fairly comprehensive approach to supporting the attraction, matriculation, the transitions, a comprehensive approach to helping people get into the health professions, especially from certain communities. So another of the examples was just emulating models of things that we already know work. And our healthcare provider incentive programs are another thing that we know work. So our first step was brainstorming, and we came up with a big list of very different ideas. And the next step was to try to make sense of that list. And so can I see the next slide, please? Thank you. So this is the full list, and we're not going to read these now, but I've sent, you should all have a copy of this spreadsheet sent to you by Mark or OHA staff. And I am later going to invite you to take a look at that and comment on it. But for right now, let's just go to the next slide, which is an attempt to make sense out of or organize that main list. So the next thing we did was we tried to organize those lists along two dimensions. And the first dimension is the stage of a person's career. And so from the pre-career phase, where we're trying to instill the interest, build people's strengths so that they can be better applicants, support people through the application process to get into healthcare professions. The next phase would be the training phase, from matriculation to graduation and certification. And what are all the kinds of ways that we can help people who want to become health professionals enter and get through the training phase. And the next is the practice phase. So that transition to practice, examples that first-time homebuyers program would be the kind of thing that would be helping people with the transition to practice. And then also how those kinds of programs are steps that we could take to help people become integrated into the community in a successful way. And then a post-career phase, what are the things we can do with those that have left their successful health professional career, and how can we harness the wisdom? For example, bring those people back into the position to mentor or support trainees as they move through the process. So that's the first dimension, was if we organize our suggestions according to what phase of healthcare professional development we're intervening. The second dimension was, at what level are we intervening? So there are some interventions starting at the bottom here, where we're trying to do something directly with potential trainees. Healthcare day camps that try to get middle school or high school or college level students interested in healthcare, for example. There's another level of support that might be in terms of supporting faculty. Those things that will increase the salaries and development potential, advancement potential of faculty members are things that will help us build our training capacity. The next level of intervention would be with institutions and organizations. What are the things that we can do at the institutional level or the organizational level to enhance the training and retention of employees, healthcare professionals? Then the next level above that would be community. What are the things that communities can be doing? And finally, the statewide level, what are the things that we do statewide? What kinds of programs or things can we do at the statewide level? So we try to organize our recommendations into these two dimensions by the level of intervention and the stage of training, which, next slide, please, gave us something that looks like this. It can help one see the sort of places where it's most dense and places where it's most sparse, but it helps give, this is meant to, and I know you can't read the individual items here, but all of the items are here organized according to where we're intervening and with whom we want to intervene with. And that helps with the next stage, which was the who, what, where, when, and table that we all developed. So next slide, please. Thank you. So the next thing we did was we asked each person who had recommended or made a particular recommendation to then specify the details of what's that particular idea, where will that be implemented, when, who would be responsible for it, and so forth. And this gave us a little bit of a sense of how these things might actually work. And that's going to lead, hopefully, to our understanding which ones are going to be easy wins, which ones are going to be take a little more work, and maybe which are going to be out of reach without a lot of effort and a big lift. So next slide, please. Back, there we go. So recognizing that we need to get where Elena and her group have gotten, we tried to figure out how to combine those 20-some recommendations into a single, more condensed or handful of items. And what we came up with was these themes. So members of our group looked at the overall list and tried to come up with the themes that they thought they might be organized according to. And we combined those themes, reached a consensus that is these 5. A number of the recommendations have to do with funding and resource allocation. A number of them have to do with awareness and recruitment. Others are at the education and training level. Again, then next at the healthcare worker support and advancement level, and finally community integration and belonging. And adjacent to each of these terms are descriptive paragraphs, which you can read on your own. So that's basically where we are now. And the next thing we have to do, next slide, please. Next slide. Here's a famous cartoon from the New Yorker. Go back one, please. This is some kind of scientist or something, and he's got lots of complicated formulas on the left and equally complicated formulas on the right, but the scientist hasn't actually figured out how it works. And so in the middle, it says, then a miracle occurs. That's kind of where we are now. We need the miracle that gets us from our 22 or so complicated recommendations to something that our intended audience can actually do something with. Next slide, please. So the next things we need to do are group our recommendations, the big list, into the smaller list of themes. What I think we will end up doing is we will list those themes as 5 major recommendations or categories of recommendations, and then we will include the entire list with more details in the appendix. One thing I've struggled with, and I would appreciate folks' views on this, is how can we emphasize a comprehensive rather than a piecemeal approach? Meaning, I think the most successful programs, and I bring up the Northwest Native American Center of Excellence as an example, try to be very comprehensive. In other words, it's not just attract some people to healthcare, send them off to nursing school or dental school or whatever it is and say adios, have a nice day, but support them all the way through the process. Because if we just attract people to healthcare professions, but don't support them in the training process, in the transition and community integration, we're not likely to see nearly as much success. So we want to emphasize the importance of a comprehensive rather than piecemeal approach. We're going to need help from the OHA in terms of current policy approach, and we've already got some help from Mark and others on that point. And then from you all, the entire committee, it would be great to have feedback about this recommendations and approach. Next slide, please, if there is one. I can't remember. So go ahead to the next slide. Okay, so back one slide, please. So I think one of the first key things we can do, first of all, let me ask, because we're at the discussion part here, from the members of the subcommittee on development and retention, any comments or additions from subcommittee members about what I've just said? What did I leave out? Okay, well, speak up if you if something occurs to you. The next thing I want to mention is I really appreciated the public comment from Kimberly Lindsay of Hefner about reciprocity. And unfortunately, instead of decreasing our number of recommendations, that increased, because I think we'll add her recommendation about streamlining the process of transition for incoming healthcare professionals. The last thing we want to do is find health professionals from other states who want to come here and help us out, who can't get their appropriate licensing or certification in our state. So we're going to do that. I want to ask the other subcommittees and subcommittee chairs about overlap. One way we can consolidate is if there's something we're doing or you're suggesting, are there items that really belong to the diversity group or the wellness group or are shared? And so if anyone identifies stuff on this list that looks like it belongs to or is an overlap area, or if you find that later, that would be helpful because we can reduce the total size. And then the last thing is feasibility or operationalization. I think we want to try to find things that is Mark, you've got your hand up.
I didn't mean to interrupt, Paul, but in response, does do things work for the other groups? Do they fit in other places? I was reminded of, I can't quite get it right, but there was a John Muir quote around, if you tug on anything at all, you'll find it's connected to everything else in the universe, something like that.
Yeah.
My invitation is for your subcommittee and all the subcommittees to not worry too much about overlap or even redundancy. Sometimes redundancy can amplify a good idea. So that was my response, is to not worry too much about trying to take away your discussions and put them into the better or the more right bucket.
Yeah, okay, fair enough. Dr. Hemmings, you've got your hand up.
Yes, I'm thinking about Kimberly's comment about reciprocity.
Yeah.
And how that fits into the context of diversity, including diversifying the workforce. And I'm just looking at figure out how to assist with relocation costs for those who reside outside of the state and within a certain radius within the state. And I think that brings into place something to consider is if we, if one of the goals here in terms of creating or increasing diversity within the healthcare workforce, and where does the reciprocity piece fit into this piece here about I know I came up with it, the relocation cost, and I know for a fact that it's within a lot of the behavioral health, I know for social work board, it's taken months for folks to get their license. And I'm just wondering if, Kimberly, I think mentioned that this individual actually moved back home. And is there is it possible if we're not, I'm not sure, I'm trying to understand how much control does this committee have over the individual boards as it relates to changing the reciprocity component of each board? That's one. And should we consider putting in some kind of a gap funding for people who are relocating here from other states in terms of receiving their license? And there's some occupations where you can't begin work until you actually have the license.
Yep.
And if you're not able to receive an interim, a few years ago, you used to be able to get an interim license, and some states do that. But I noticed that that's not necessarily occurring here as often, especially within the social work board. So I'm rambling, but that's kind of like where my head is as I listen and take a look at that piece about relocation expenses.
No, thank you, Dr. Hemmings. That's thanks for pointing out the connection between Kimberly's point and the recommendation you had made earlier. And I think these ideas for how can they streamline the licensing if possible? I don't think we have any control, but we can certainly have input. Can we streamline the licensing process? Can there be interim licensing? And is there some way to provide gap funding so people don't go on food stamps while they're waiting for their license? I know I've seen this personally in my own experience. I've seen this happen where the licensing takes a very long time and people are pretty stretched. I see, Elena, you got your hand up.
Yeah, just adding to that conversation, another related thing that I know that's at least happening in the dental world is the idea of license compacts. And so where a series of states agree to, if I wanted to practice in Washington, I wouldn't need a new license. I could use my Oregon license and practice in Washington. That's hypothetical. That doesn't exist yet, but that's what a compact would mean. And so I know there's been some work in other states about having multi-state compacts for portability of licensure. I know that there's tricky stuff when it comes to border cities. So like Medford is one where if someone has an Oregon license and it's easier or there's more job opportunities, or they can get paid more at a California clinic just by driving 30 more miles across the border, it can have some backlash in the workforce ramifications. But I think that we'd be remiss not to at least include that in a conversation of license portability, if that's something that we want to include in this report.
That's a great point. And I think the increased availability of telehealth and all of the telehealth and out-of-state care that happened during the pandemic might have started to break down some of these barriers, but that's a great point. Thank you for that. So some of this is not about creating new practitioners, it's just enabling those who are already trained to practice in our state. Any other thoughts from subcommittee members, Subcommittee on Growth and Development, stuff I left out, stuff that you feel we should emphasize more? I'm trying to use the 7-second rule. A colleague of mine said with students, when you ask a question, you have to wait at least 7 seconds for students to speak up. I want to make an editorial comment. It has to do with language and depersonalization, which I think is related to burnout. And so I was thinking in the course of this conversation, if you've been in healthcare a little on the long side, as I have, about 50 years, the language has changed. And in many ways, we use language that is very depersonalized. We used to do care at the bedside. Now it's the point of care, which is a term that comes from commerce. We don't talk about people, we talk about providers and encounters. And a lot of the language is very depersonalized. And I think the depersonalization, there's some literature on that. It helps to contribute to burnout. I'm on my 7th primary care doctor in about 25 years. In any case, I bring up language because I would hope that in the writing of our reports, we can use language that doesn't further contribute to the depersonalization by making everybody kind of anonymous. And all of the, I don't know if anybody sort of gets what I'm saying, but you hear it in the language, and language is pretty important in terms of how it makes people feel about their work and the meaning of their work. So we've got a lot of work to do in our subcommittee in terms of condensing these recommendations. Obviously, there isn't time for all of it now, but I would encourage everyone and request of everyone on the committee, if you could at least glance at this list of recommendations that we've come up with, and any suggestions, comments, additions. If you think something looks like an easy win and is a great idea, let us know. If something looks like it's never going to happen and we should de-emphasize it, let us know that too.
Perfect, Paul. Any other further comments for Paul and his subcommittee work?
I just had a comment that, not everything requires money, funding. There are some things that requires us to think differently, right? In terms of how we change systems, and not throwing money, at things don't always make it better, right? So I just want us to be mindful of that, because I think a lot of times is, turn off when you put out these policies and there has to be funding or monies associated with it. And people always look at that and say, well, here we go again, we're spending more money that we don't have. But I do think that we need to think more systemically in making change. And it's not always about adding additional funds.
Thanks so much for that. And since you're on the subcommittee, would you remind me, please, when we're putting together a report and have a draft of it, I think what you just said needs to go in the executive summary, so that the audience for our report understands that we recognize exactly what you just said. Everything doesn't require more money. Sometimes we just have to rethink things and come up with new ways of looking at it. Thanks very much.
Welcome.
Perfect. Thank you, Dr. Hemmings. Okay, with that, we're going to go ahead and take a break now. Larissa was called away for an emergency at work and is not here to do her presentation. However, her slides are in the packet. There is a meeting on Monday for that subcommittee at 11:35. So feel free to join and go over her slides. And then we'll go ahead and take about a 10-minute break right now. We're pretty much on schedule. So feel free to turn your cameras off while you're on break, and we'll see everybody back at 11:10. Hi, everyone. It is 11:10. Committee members, if you are back, if you could turn on your cameras to let us know that you are back with us, that would be great.
Hey, I am back. Are we resuming meeting where we left off or going back to the other slides?
Nope, we are going to talk about the equitable health professionals shortage designation. However, before we do that, Jessica, I just wanted to take a minute, acknowledge two of our healthcare workforce committee members are here. Gabby, if you would just take a minute, introduce yourself and your organization and pronouns if you are comfortable doing that.
Hi, thank you, Laura. My name is Gabby Carrillo. I am the Director of Clinical Placement at Sumner College.
Thank you, Gabby. And Jason?
Hi, everyone. My name is Jason Johnson. I'm a committee member. I use he, him pronouns, and I am a dean at Portland Community College supporting a portfolio of healthcare programs on the credit side and the non-credit side.
Perfect. Thank you both. Okay, I think we will go ahead and turn it over to, we have a few folks here. We have Liza Root, and she is HIPSA and NHC specialist. We have Terrence Saunders, Joe Bergeron, and Leah Festa with OHA, who are going to talk with us and give us a little presentation about developing equitable health professional shortage designations in Oregon. So I will turn it over to you folks.
Thank you, Laura. Thank you for the introductions. Let's see. So just wanted to, I think next slide would be. So our team has been working on developing equitable health professional shortage designations in Oregon. And I'll provide just some background information, and then I'll hand it over to Leah Festa to kind of explain a little bit more about what we're doing. All right, next slide. So the Healthcare Workforce Initiatives team in the Oregon Health Authority is responsible for identifying health professional shortage areas, often referred to as HIPSA designations. HIPSA designations are national standards developed by the Federal Health Resource and Service Administration, also referred to as HRSA, to determine healthcare access or lack of access in an area. OHA is committed to eliminating health inequities by 2030, and we cannot do so if our systems to identify health access do not consider health inequities. So next slide. It's time to expand the health professional shortage designation processes beyond the framework of the federal government to better understand the needs of our communities. And we are most interested in how we could do this and impact our state-based provider incentive programs to reimburse health professionals to provide care in certain areas of the state, but it's certainly not limited to that. Next slide. So this is just some background on HIPSA designations. Designation refers to the designation of a health professional shortage area. The primary purpose of a HIPSA designation is to inform the distribution of federal resources around provider recruitment and retention. They are a way of analyzing healthcare access or lack of access for all people in a geographical area, which is referred to as a geographic HIPSA designation. It could also look at a particular population in an area And those 4 areas are low income, which is under 200% of the federal poverty level, migrant and seasonal farm workers, homeless. This is a HRSA designated term that they use. Homeless is people experiencing houselessness, Medicaid eligible populations. And then certain types of facilities receive auto HPSA designations, and those include federally qualified health centers, some rural health clinics, and federal and state correctional facilities, as well as Indian Health Service facilities. Next slide. So within a health professional shortage area, every HPSA receives a score, which is determined by a scoring criteria that was developed in the 1980s and has not changed since then. HPSAs are used to determine federal funding for recruitment and retention resources. They are separated by discipline, and only certain providers are included when they look at that scoring criteria to create the score. They only look at medical providers in an area. For dental health, it looks at dentists. For mental health, it's psychiatrists. Primary care, it's MDs. And when you're looking at a HPSA score, the higher the HPSA score, the greater the need and opportunity for federal resources to be deployed to an area. So when, next slide, please. When we look at what goes into the score, all 3 disciplines calculate population to provider ratio for a maximum of 10 points. Percent of population below 100% federal poverty level, that receives a score of a maximum score of 5 points. And then travel time to nearest source of care outside of the HPSA designation area with a 5-point maximum. And then next slide. This is just an example of the mental health score. So in addition to the population to provider ratio, the federal poverty level score, and the nearest source of care, there are a couple different additions to each discipline. So specifically for mental health, it considers an elderly ratio, youth ratio, alcohol abuse prevalence, substance abuse prevalence. When we consider and look at dental score, it's looking at fluoridation rates. And for primary care, it looks at low birth rates. So that's just a high level overview of what a health professional shortage area designation looks like. And I wanted to I think you went back. So you want to go forward. And then I wanted to hand it over to Leah. There we go.
For a second, I thought, uh-oh. But let's go. Good morning, everyone. So as Liza just explained, the HPSA score is a national standard that was developed and used by HRSA. And our Oregon Primary Care Office uses it to determine the level of healthcare access in an area. And so subsequently, where some resources are focused. And over time, the team identified that there are several prominent gaps that we've noted in the HPSA score. And so first, the HPSA scores are limited to this population to provider ratio for the most part. And they do not consider diversity, culturally specific needs of the population that the provider is serving. So that was one gap we've noted. Second, a population threshold is required to receive points for the population to provider criteria. So Therefore, we find rural communities don't reach the threshold to receive a lower score, even though recruitment and retention is a barrier to care. And then finally, we did find that the HPSA scores have a limited consideration for social vulnerabilities, such as housing, transportation, etc. Next slide. So with all of this in mind, we've been conducting listening sessions with many different organizations across the state to learn more from community partners on how we can better inform the healthcare workforce investments in communities. And we have heard so much rich feedback from community. And as we know, not all of this feedback fits within our unit's purview, but we thought it's very important to share these findings, and our group wanted to ensure that we're really elevating this feedback and expertise through appropriate channels so that hopefully it can be considered in other avenues. And that brings us here today with this presentation. So our hope here is to share this feedback that we've learned from our community partners with you all so that it can inform your subcommittee planning and recommendations. And so I'm going to pass to Joe to dig a little more into who we've talked to and what we've found out.
Great, thanks, Leah. So starting then in the summer of 2022, about a year ago, a little over a year ago, we started reaching out to partners and providers to ask if they were available for a short listening session to share their observations and expertise around these questions that Leah and Liza were mentioning around how could we potentially expand the scope of investments to combat inequities beyond the current incentives that are linked to HPSA designations. And we heard back from it's a total of 30 different organizations over the last year and have had listening sessions with each. So this slide identifies the FQHCs and the dental care providers and the state offices that are engaged statewide on many of these, on many community-based health roles. So the FQHCs, for example, are across the state: Eastern Oregon, Central Oregon, Southern Oregon, Willamette Valley, Portland metro area. Next slide. Also heard from a number of other nonprofit and community-based providers and organizations, small and large. So on this list, you'll see large CCO like HealthShare, smaller community-based health groups, statewide associations like Oregon Primary Care Association, local workforce development boards like East Cascades Works, Willamette Workforce Partnership, nonprofit health organizations like OCHIN that does health records development for community-based health organizations. So we got a lot of different perspectives from around the state. Next slide. So these are some of these next three slides identify some of the common themes in our preliminary analysis of the listening sessions. We haven't done a comprehensive analysis of all of our notes from all of the sessions, but a preliminary analysis identifies a number of common themes. So first, we have the social determinants of health, which came up in almost every listening session when we're asking about developing Oregon-specific shortage designations beyond the federal HPSA designations. Very frequently, the individuals that we were interviewing in the listening sessions would have something to say about, you know, if there was some key measure of social determinants of health that you could be using to develop a state-level shortage designation to then expand the workforce, increase access to care, improve health outcomes. So identified that here first. Some variation of discussing employment, education, healthcare access, housing, transportation, racism and discrimination in the workplace, other workplace conditions. Second, a very common theme was some variation of healthcare systems and trust or lack of trust in the system, talking about racism within traditional healthcare systems, a lot of conversation around the inability of traditional health systems to adequately reach people from underserved communities, including migrant seasonal farm workers, a common population identified in listening sessions. Next slide. We also frequently encountered some conversation about language access, need for expanded interpretation services, disparities in rural and frontier areas, especially acute gap in behavioral health care, need for more culturally specific providers, more diverse representation within the workforce to meet the needs of diverse patients, allowing the community to define health and what it means to them, different in urban, suburban areas versus rural and frontier areas, for example. Inequities in the health of a community, examining community health by zip code, for example. Next slide. Other common themes emerging from the listening sessions: need to rapidly expand the traditional health worker workforce, the THW workforce, additional research needed for providers by insurance type, low wages of many healthcare providers came up frequently, such as peer support specialists and medical assistants, for example. Utilization rates of healthcare services, both insured and uninsured. Importance of telehealth services in primary care and behavioral health and dental health. Travel time to nearest provider. Patients can be forced to miss work and school to see a specialist, for example. Many of these themes that are emerging from the listening sessions are in alignment with some of the research around the development of state level shortage designations. And we had also done a short literature review that identified Nebraska as one of the, it's not common, and Nebraska is really the only example of a state that has developed an elaborate state level shortage designation program that moves beyond HPSA scores in order to expand scholarships for healthcare providers in that state. Most of they use a scoring mechanism around rurality. And so most counties in Nebraska are designated as, have a shortage designation around rurality, and then they assign specific service areas as shortage areas. So it's a dozen different healthcare roles, from psychiatry to primary care to pediatric dentistry. So it's a pretty elaborate program to invest more scholarships, for example, in the state. Next, Terrence is going to discuss what we have in mind for next steps.
Grand Rising, good morning. Terrence Saunders, he, him, his for pronouns, behavioral health workforce equity coordinator with OHA. And I just want to put into context the reasoning for this presentation and kind of the timing as well. So the purpose of this presentation during this meeting is to hopefully inform the recommendations that the subcommittees are working on for the report for the Healthcare Workforce Committee. And that's the general purpose of bringing this information during this meeting as well. So a couple of next steps that we are working on right now, or soon to be working on shortly starting next week, is to complete all the listening sessions, making sure that we do a gap analysis to ensure that we heard from all regions of the state, or at least have done formal outreach and do our due diligence as a state, to analyze findings, to research available data that was also mentioned in one of the questions for the various listening sessions that we've had, and to really dig in to see what's available at the county or regional level within Oregon, as data seems to be a recurring theme for or at least a reoccurring barrier in collecting quality data. We'll also formulate some sense of report, whether that's a summary document. We do hope to share those findings back with the communities that we've heard from. And also that the findings from this project will hopefully inform provider incentives, resource allocation going to communities, and all the common themes that Joe mentioned previously. We hope to include those into the scoring rubrics for the healthcare provider incentive program and other incentives as they come online in the next couple of legislative cycles. Next slide, please. So this is our contact information. We'll drop our emails into the chat, but if you can, please go to the next slide as well. Maybe another slide. And these are the questions that we utilized in the listening sessions. So the first question, and these are really broad questions to get folks and organizations thinking of what needs to be included in these designations. So in the population you serve, which racial or ethnic communities are experiencing health inequities? Why? What is the potential impact of resource allocation to these communities? And how do we measure the impact, most importantly? Next slide, please. And the second part of the questions that we ask is what could be the impact of intentionally recognizing an inequity and making investments to improve it? And where should we prioritize this recognition? Also looking at what data sets should we seek out for this work, both available and those that aren't sure that are currently available. So that's the phase that we're going to be in starting right after this meeting, likely going to spill into the next couple of weeks, is analyzing what data is actually out there to really hone in on where can we use as valid data points to point out the inequities. And how should we modify or enhance strategies to ensure community needs are recognized through an Oregon-specific shortage designation? So this won't change the HPSA model, but Oregon does have the ability to change what Oregon collects, and that's, again, what this project is focusing on. I believe that is the last slide. And we would like to open it up for questions or feedback for the presentation.
Committee members, are there any questions or comments? I can't see everyone's hand, so feel free to speak up if you would like.
I think.
Oh, go ahead, Ian.
Okay. I'm glad to see the social determinants find its way into the conversation. Really, if I've heard from a group of providers anything more and more often, it's that they come into work and have to address both medical issues and the social determinants of health. And without those resources, the burnout rate is huge. So certainly something we've looked at in clinic. And I think that as part of our conversations needs to be included.
Absolutely. Thank you, Ian.
Okay, I have a couple questions for you guys. I was trying, when I was looking at the presentation, and you might have covered this and I might have missed it, but when you were doing the listening sessions, were you focusing on organizations or areas, I should say, that potentially could have a higher HPSA score if we incorporated the health equity piece into the designation of the HPSA score.
So I can jump in and try to answer that question. So I would say it wasn't an explicit focus, but naturally a lot of organizations that do have low HPSA scores provided feedback. And I'm thinking of the culturally specific providers in the Portland metro area, for example, where they generally have lower HPSA scores because Portland is very resource compared to the rest of the state. So that wasn't an explicit focus, but naturally that did come out quite a bit.
Okay. Perfect. That explains it, because I wondered when I looked at the list of organizations, so you had on there Regional Health Equity Coalition. So there's like 4 of them, I think, in the state. So I wondered if you spoke to all of them or if you just focused on maybe 1 or 2 in a certain area.
Liza, do you want to take that one? I think that was one of the listening sessions that I was not able to present at, but I do believe it was through the OHA Regional Health Equity Coalition meeting. So all the folks were present, but Liza, feel free to jump in.
Yeah.
I can answer that too, because I was the one who facilitated that connection. Excuse me. We had worked through our equity and inclusion division to send out an invitation to all the regional health equity coalitions, and we heard back from one. I believe it's the Oregon Health Equity Alliance, which covers the Portland metro area. So that was the one regional health equity coalition we did the listening session with.
Perfect. Thanks, Neelam. And it's kind of making a little more sense to me, I think, because I didn't see any coastal involvement at all when in any of the listening sessions. Say I work a lot on the South Coast, so the FQHC there is Coast Community Health. So I didn't see a lot of the coastal participation, but they have a pretty high HPSA score anyway. So so that's why I wondered about the connection between the entities that you spoke with and whether or not their current HPSA score played into that at all.
You know, Laura, I'll also mention that the listening session that was done with the Oregon Primary Care Association, I believe that included like close to 20 FQHCs.
Okay.
The entire list isn't provided, but we, be happy to provide more information about the range and reach. And of course, if you have any suggestions or if any of you would like to participate in a listening session, we would welcome that feedback.
Nope, that's okay, Neelam. I was just, I'm always championing for the South Coast because of what we encounter there. So that's why I wondered, but no, that's great. Thank you. And thank you all for doing this work. I'm sure it was not easy bringing all those people together to get all these sessions done.
Yeah, and I'll just add that we've reached out to about over 100 organizations all across the state as well. So only 30 participated, but there was direct outreach broadly across the coast, Eastern Oregon, but we can't force people to participate in the listening sessions for whatever reason. So I just wanted to mention that piece as well.
Yep, and I think I would just offer, Terrence, if you, I know you can't do this all the time, but if there's a particular area that you wanted to focus on and you couldn't reach anybody, feel free to reach out to, committee members or CCO folks, because a lot of times we can nudge them a little bit and say, hey, answer this email and participate on that. So I'm just offering myself as a resource. If you have difficulty, please feel free to reach out anytime, and I will give these folks a kick in the rear end to help.
Sounds good. We will likely send you an email in the next week or two if when we recognize that there's major gaps. So
Feel
definitely.
free. Okay. Committee members, do you have any more questions, comments, or feedback? Elena?
Yeah, just to the first question there, the what could be the impact of intentionally recognizing ... I'm curious. The Nebraska thing surprised me. So what could you just speak a little bit more about that? Like, have they what has been the what drove them to make their own system, and what has been the impact? Were you able to like talk to anyone in Nebraska to share? Was it helpful? Was it surprising? I'm always curious to turn to learn from folks that have done it before.
The Nebraska case came up in our literature review, and I don't know the origin necessarily. I mean, I imagine because it's a very rural state, that they've taken, that they've done a lot of work around serving rural populations. But we used that as an example, if Oregon was to develop a new state-specific shortage area designation to incentivize providers further than with the existing federal program. We thought, Nebraska is a state that could provide lessons because they've incorporated that rurality as a key shortage metric. And then they've connected it to specific service areas. And let's see, at the last, I think it was 10 different service areas: physical therapy, pediatric dentistry, mental health, nurse practitioner, families, doctor, general surgery. So much more a diverse array of providers than with the HPSA program. And so we thought, and it's all but 2 of Nebraska's 93 counties that have been designated as shortage areas and 1 or more primary care specialties. So this, that state has, they're able to expand their incentive programs like scholarships and loan repayment further than with the federal designation alone. So just sort of a potential role model or example where lessons can be drawn.
Well, yeah, and I also wonder, I mean, we just finished, we're onboarding 3 dentists right now down in Medford. And so it's all kind of fresh in my mind. And I wonder what, I guess that's what would be possible. Can we think beyond, to Dr. Hemming's point earlier, can we think beyond just the money, and if there might be like marketing resources or ways to get I'm thinking almost like a facilitator, like someone that can, okay, this is true, we hired a dentist from Iowa and she didn't know that Oregon dental licenses had a separate nitrous oxide application piece. And so she showed up here and she's like, oh shoot, I can't do nitrous, I can't do laughing gas. And so I wonder if there might be if that rurality, and often people don't think of Medford as a place that they want to move first and foremost. And so I wonder if we could think outside of the box as far as what incentives we're providing, and if some of those incentives could be like marketing or like a chaperone through the relocation process. That's what came to mind for me.
Thank you. Oh, pardon me, Mark. Before, I just wanted to mention to Elena, I'm going to put the link to the latest report from the, let's see, it was the latest status update from the state of Nebraska. It shows how these tools are, a success for recruitment and retention in rural and underserved parts of the state. So this was a document that I used in the literature review.
Great, thanks.
Sure. Mark?
Yeah, thank you. I'm sorry to speak over you, Joe.
Not at all.
I was asked to provide a little background about my awareness of Nebraska and their particular system. A lot of it goes back to leadership and longevity. Tom Rauner is the name of, he's basically the state rural workforce director in Nebraska. He's retiring this year. He has for over a decade put that approach together, that because Nebraska's a rural state, they have a very high concentration of certified rural health clinics by CMS. He made the decision quite a while ago. He told me that he's not going to bother too much with the National Health Service Corps and with the resources from HRSA, and instead lean into the resources from CMS through the rural health clinics, the Federal Office of Rural Health Policy, that part of HRSA. And yes, exactly. Now, it's been a strategy that seems to have worked for Nebraska as a very rural state to track the availability of licensed providers there. And they do have robust resources from community foundations, from the state, from other places, to be able to target for or focus on for rural in particular. And they've also done work to determine that, like Terrence spoke to, there are places in Oregon that don't have high health professional shortage area scores and aren't candidates for attracting NHSC providers. But they've been able to make recruitment and retention work in Nebraska through resources like the Rural Recruitment and Retention Network, or 3RNet, their state funding, community funding, with the focus on rural. That's just to add a little bit of background along to what was provided. And then my final offer would be, it's a terrible expression, don't throw the baby out with the bathwater. I think that one of the real values of this Oregon approach is to be able to offer resources alongside of those communities where they don't have a high HPSA score, but we know that they're in need and that we know resources would make a difference. Thank you.
Thanks, Mark. Any other comments or questions?
This is Leah. I think I'm curious for committee members if this information was helpful and if the subcommittees feel like they could incorporate this into the planning that they're doing.
Subcommittee chairs, I will invite you to speak on that. Paul, you have your hand up.
I'm not sure how we'll use it, but I applaud the work. I think it's great to start trying to go past the federal work and try to find, who's not getting care that they need, that we haven't been able to identify with previous mechanisms. So I think it's great. I'd love to have heard from the 70 that you invited that didn't respond. But I think it's great work that you're doing, and would love to hear ideas about how we can incorporate it into our subcommittee work and in the full committee work.
Yeah, and I'll echo that. I mean, I think the thing that stands out most to me, I'm thinking still of Coy's comments earlier about the intersections of identity and burnout, and then thinking about Ian's comments about the intersection of the degree to which our patients experience the social determinants of health and burnout, that those two things are created. So I'm just thinking it would be interesting to further index the burnout information against this modified HPSA score to say, is burnout higher in higher HPSA score or whatever new scoring rubric system we think of. So I'd be happy to incorporate that into our report as well. That's the main thing where I see it being helpful.
Perfect. Thank you, Elena. Any other committee members? Okay, not seeing any hands or hearing any voices. Thank you all for that presentation. That was really interesting. It's generated some thoughts, definitely. So thank you all for being here. I appreciate it. And we will go ahead and move on to, we're going to have a discussion around the healthcare provider incentive program. And we will have some folks with us that will be giving us some discussion on the recommendation on the distribution of the provider incentive fund for 2023 through 2025. And Leah is going to stay with us and join us for that, Leah Festa. And then Jill Boyd is here and she will also join Leah to have that discussion with us. So I will turn it over to Leah and Jill.
Hi, everyone. Back to generate a few more thoughts, hopefully. My name is Leah Festa. I didn't quite introduce myself last time. I'm the Healthcare Provider Incentives Program Coordinator, and I am accompanied by a few of our team members. Jill is here, and she'll be presenting with me. She is our Healthcare Provider Incentives Program Project Coordinator. We've got Jamie Taylor, who's our support specialist, and I believe from the Office of Rural Health, we're joined by Bill Thunder, and he is our Program Manager of Incentive Programs. So we've got a great team, and we're excited to give you a preview today. So we'll go on to the next slide. Okay, we'll go to the next one again. Thanks. Yeah, so the purpose of our presentation today is to provide a brief overview. We thought we'd have a lot less time, but we're ahead of schedule. So we'll be able to provide an overview of the Healthcare Provider Incentive Program. And that will include a brief description of each incentive, as well as an overview on the Healthcare Provider Incentive Fund. So I'm differentiating the program from the fund here. And then we're going to talk about the role of this committee in the 23-25 allocation process. And that's our biennium. So 2023-2025 biennium. And we're really hoping this information will provide context for the October special meeting that's coming up. And that will be during which you will be voting on a proposed budget. So we understand that our presentation is a fairly quick overview today, and I just wanted to let you all know we're available anytime. We will answer questions, set up calls, whatever you need. So as we go through this, I know thoughts and questions and ideas might come up, so just know that we are available. So our outline today is, first, we're going to start with an overview of the fund. And then Jill is going to take us on a tour of the healthcare provider programs. And then we will preview some considerations that the team has noted for this upcoming budget proposal. And then we're going to round out the presentation with a moment for questions and comments. So next slide. So we'll get started with the fund. Next slide. A bit about the legislation that brings us here. The Oregon legislature passed House Bill 3261 in 2017, and that requires the Oregon Health Policy Board through OHA and its partners to do a few things. First, it creates the Healthcare Provider Incentive Fund, which consolidated multiple incentives into a single pool. Those incentives include loan repayment, primary care loan forgiveness, Scholars for a Healthy Oregon initiative, and Scholars for a Healthy Oregon initiative like, and then the Rural Medical Practitioners Insurance Subsidy. And Jill's going to tell us about each of those in just a few moments. It also requires that we conduct a healthcare workforce needs assessment and evaluate the effectiveness of our state financial incentive program. And that will come in as an important factor into this as we move along. So next slide. So now your role. The Oregon Health Policy Board relies on recommendations from this committee and the Healthcare Provider Incentives team in making its allocations each biennium. And so the board may request adjustments if needed, but a few things to keep in mind as we work together is the fund and the program are administered by OHA in collaboration with our wonderful Oregon Office of Rural Health partners. And then the fund and the program are under the policy direction of the Oregon Health Policy Board. And the fund allocation is required to be based on the healthcare workforce needs assessment and the biennial evaluation of our programs, our incentive programs. So those two reports I just mentioned that are legislatively required are also required for us to base our allocations on. And I am going to put those two report links in the chat right now, because I don't think you can, if you don't have, let's see if I can send this. If you don't have it open, you might not be able to click on it. I think it's not wanting me to send the link. So, okay, we'll make sure those links are in the chat eventually, and hopefully you can click on them in the materials in the PDF. So these are, as I mentioned earlier, the presentation is a primer for next month, October 4th, 2023, our special meeting of the Healthcare Workforce Committee, during which you will review a proposed budget for this upcoming biennium. Our team will present that and provide recommendations. And once those are approved, after we've discussed them, they'll be sent to the Oregon Health Policy Board. So in preparation for that presentation, we are asking you to review those two documents, the needs assessment and evaluation. These two reports are really the primary sources our team uses to propose funds. And we'll be tying this data from these reports to our budget proposal. So hopefully doing some of the work there and being able to really tie our data to our proposal. So next slide. This slide, it shows the amounts that legislature has allocated each biennium since 2017. And you can see the amount has increased each biennium. We jumped from 18.4 last biennium to 19.2 this biennium. And we have an additional 6 million that was earmarked for behavioral health. Next slide. I'm going to pass the mic over to Jill to provide more information on the incentive program.
Hi, everybody. I'm Jill Boyd. I use she, her pronouns, and as Leah mentioned, I'm the Healthcare Providers Incentive Program Project Coordinator. And I'm going to just provide a brief overview for new members or just a refresher for any of our existing healthcare workforce members around the programs that we have within our incentive program at the Oregon Health Authority. So we're going to start with the loan repayment. And I did put the links, I hope they work, in the chat. I was able to pull them up while Leah was speaking. So all the information that we're sharing about the different programs can be found in greater detail in the evaluation report. Okay, next slide, please. Thank you. So the first program that we have is loan repayments. And this supports existing professionals in repaying qualifying student loan debt in exchange for a service commitment at a qualifying practice site. We have had about 17 quarterly cycles thus far and have estimated about $16.7 million to over 295 practicing clinicians across the state. So these awards are our practicing healthcare professionals. We do provide tax-free funds to repay up to 70% of qualifying student loan debt in exchange for a service commitment. That averages out, the maximum is about $150,000 per student. We did have some wonderful changes with the behavioral health loan repayment. Did transition in April of 2022 from our program to the Behavioral Health Workforce Initiative under House Bill 2949 and House Bill 4071. As you can see in the graph to the right, the applicants have been consistently exceeding the award amounts. We saw a little bit of stifling, I think, around COVID, but I think we started building momentum up again in 2021 and 2022. And we anticipate between 2023 and 2024 cycle years that it might level out a little bit based on, COVID kind of passing that initial hump, but who knows? That's kind of our anticipation. One of the things that we are noticing is that provider and clinics do express the need for loan repayment for retention and recruitment. So that's something that we wanted to highlight and think about as we go into our budget for the next biennium. Next slide, please. Our next program is, our incentive is the primary care loan forgiveness. This is an award for full-time students participating in approved rural training tracks. They receive funding during their education in exchange for a future service obligation. We've had 5 annual cycles. Oh, okay, not sure what happened there. We've had 5 annual cycles and have awarded about $2.6 million for 51 future clinicians. We've had about 5 we have had 5 schools and 6 clinical programs thus far. The maximum scholarship for each student cannot exceed the highest resident tuition rate at the publicly funded health profession training programs in the state. And this incentive particularly is prioritized for individuals that are on an approved rural training track. And you'll notice again that the numbers had kind of dipped slightly during COVID, but we do have students from OHSU, Pacific University, Western University of Health Sciences, and the College of Osteopathic Medicine of the Northwest, or Comp Northwest, participating thus far in this program. Next slide, please. Moving over to some of our scholarships, most of you may be familiar with SHOE, or the Scholars for Healthy Oregon Initiative. This is a contracted work that we do with OHSU to administer the incentive that was established under ORS 348.303. The incentive has been about the same, about $2.5 million each year, or $5 million each biennium. And this does provide full tuition and fees to OHSU only students for 4 clinical programs in exchange for a service commitment at a qualifying practice. Some of the criteria include that you must be a resident of Oregon and accepted into, but maybe not yet started, your first year of education at OHSU. There is preference given to individual students that are from a rural heritage, as defined by the university's admission policy, first-generation college students, and individuals from a diverse or underrepresented community. We do have a little bit of information provided from OHSU. We're still working on this last biennium, gathering some information, but as you can see, we've had a total of 55 recipients and a little over that $5 million. We do believe that there's some additional carryover from additional funds, and David Robinson is the primary contact at OHSU if you have any additional questions. We're not as involved with this program as we are with some of the other ones. And I saw there was a comment. Did I miss that? I apologize. Is there 2 DNP programs, or is that a typo? Oh, I think that might be a typo. Let's go back. I'll go back and double check with our slide deck. You can also double check it yourself within our evaluation report. Thanks for catching that, Paul. We've looked at these slides so many times, I think our eyeballs are getting a little crossed. So I apologize for that. We'll get the updated information to you guys shortly. Next slide. We also have what's called a SHOE-like program, and this is to provide tuition and fees for students that are non-OHSU training programs in exchange for a service commitment at a qualifying practice site. So this has been a bit of an interesting structure. We've really changed the program from the previous biennia. We've adjusted from contracting directly with students to contracting with the training programs at the request for through our RFGA process. We've also expanded the types of training programs with varied healthcare workforce disciplines, and you'll see that in the next slide. And then we're also prioritizing for individuals who will increase access to services that are peer and community driven and that provide culturally specific and culturally responsive services for people of color and in tribal communities. And so for this last biennia, which we're still kind of in the process of distributing funding because of the way that the school year kind of maps out, we have 6 healthcare training programs that have received funding, and their details are in the next slide. So if we can go there. Thank you. So you can kind of see between 2019 and 2021, we had 3 different schools with multiple professions, and we've really expanded it with the changes to our RFGA and working directly with the institutions of higher learning. We do have, we're not exactly sure what all the professions are going to be. That's still going to be finalized. A lot of institutions are waiting till this fall to start with recruitment of their students, but this is the total amount that they have been awarded. And then these are the different disciplines of programs that are within the institutions. So we're hoping for a little bit more diversity in the workforce. And next slide. So this is one of the last programs I'm going to be talking about before turning it back over to Leah. We also have a rural medical practitioner insurance subsidy. This has been probably one of our most longest standing incentives. It was originally launched under House Bill 3260 in 2003. And the purpose is to support and stabilize the healthcare workforce in rural and frontier areas by providing partial malpractice premium subsidy payments for physicians and nurse practitioners practicing in rural areas. As of right now, we have 7 carriers that we make payments to, practicing professionals at a percentage of their malpractice premium. We have 5 carriers that are really active, 2 that are inactive but are still continue to be eligible. We have seen a steady decrease in utilization of this program over time, and we are seeing that that's really due to the health systems. There's a lot less independent practices in rural and frontier areas, and a lot of the health systems are supplementing the clinical premiums. So this is something that we're examining a little bit more closely as we develop our budget considerations for this next biennium. And with that, I think I'm going to turn it back over to Leah with the next slide.
All right. We could, yeah. All right. Thanks, Jill. Now we're going to share several considerations that the teams identified as a preview too for what you may see in our budget proposals. If we could go to the next slide. So first, as I mentioned previously, the legislature allocated $6 million of new behavioral health workforce incentive funds, and this will support resources to create new incentive opportunities for behavioral health and programs. We're excited about this. And then next, we are considering changing loan repayment eligibility requirements, and this will help reintroduce behavioral health professions as they transitioned out. We're transitioning them back in, and then also potentially expanding to broader health professions. And then adjusting the rural medical practitioner insurance subsidy funds to align with the current usage and identified effect. So you saw in that previous slide that the demand has gone down. So just kind of taking a look at the subsidy. Then we will be adjusting the administrative funds to include things like our new incentive development, some of the pathway programs, and the administration of those incentives and the increase in numbers. Of course, cost of living adjustments, we're all familiar with COLAs. Those are, for some of us, union, some not, some of the contractor staff at OHA, ORH. So we've got some staffing to keep things up and running. And then also we've been exploring some anti-racism strategies. And so we'd like to be able to put some funding behind that so we can really dig into some different ways to implement operationalize our programs in a very anti-racist way, but we're still exploring what that looks like. And then program evaluation. So we talked to you a lot about Real D in our program evaluation presentation earlier this year, and we're still working on implementing Real D, which is our race, ethnicity, language, and disability data. And eventually, we believe that OHA will announce that we will be collecting sexual orientation and gender identity information as well. So that's SOGI. So those are some things on the horizon that we're considering as we develop the budget. And we'll go to the next slide. And now we'd love to hear from you. We know this is a lot of high level information. We're not quite in the weeds of budget proposal yet, but if you have any questions about anything we presented, any comments, things you'd like us to keep in mind and consider. We also are available if you want to think about it and mull it over, we're available anytime for calls, emails, texts. So no wrong door reaching out to us. We love to connect with all of you. So I'll open the floor, and we've got Jill and also we've got Bill from ORH here today. So hopefully between the three of us, we can respond to your questions.
Paul, did you have a question?
There we are. Okay, I couldn't unmute. Yeah, I did have a question. I was looking at the loan repayment program. Yeah, I don't know if this works or not. My question is, are those, because there's a lot more applicants than there are awards. So I wonder, are most of those applicants getting the full amount of their loan repaid? And could we get more bang for our buck? Apologies to those who would get less money this way, but could we get more bang for our buck by making only a partial loan repayment and distributing those funds to a larger number of individuals, especially where the loans are very large, but the incomes are probably also better?
So I'll take an initial stab at that, and then I don't know if Bill, he's been doing this way longer than I have, and he really is kind of the number cruncher. So there is a percentage, and so every student that applies, there is a difference. So we really, in our application review process, we do examine that as well. And so we do try to maximize the number of students. We really try to focus on those that are coming from a diverse background. There are a couple essay questions that they also have to submit. And so everything is based on that scoring. So while I say the maximum is $150,000 per student, not all students will qualify for that full 70%. So okay. There are smaller amounts. So we do have some that are like, we only need $23,000 left. So we really try to squeeze out and try to get real crafty about how many, because we do want to make sure that we're covering a diverse discipline. We want to hit rural, we want to hit medically underserved urban. We want to kind of hit as many as we can. And what we are seeing is that there is just a lot more people applying for this specific program than we have funds available. And so that is something we are definitely going to take into consideration with this next biennium of funding. But yeah, and I don't know if that's the cost of school is going up. I think there's some comments in the chat I'm trying to address as well, but we really do try to squeeze every single penny, I think, out of that based on all the different types of funding that is available to us.
So you're being crafty. That's great. If Jason, forgive me for following up, but one other thing, and that is I noticed that the number of rural training track awards is relatively small compared to the loan repayment. And so just a background as I understand it, there are far fewer tracks than there are people going into primary care specialties. And the rural training track both requires that the program have a specific explicit track, and the student has to make a commitment far earlier in their training. And so there may be a much larger number of potential ones, but they're not applying because they don't have a track, or they're not quite ready to make that commitment. Sorry, Jason, you had your hand up.
No worries. I actually I had my question answered in the chat. I texted or messaged Leah directly, so I'm all good.
And I will comment to that, Paul. I'm assuming you're talking about primary care loan forgiveness, and we do recognize that as well. And that is something I think we're looking into. We have recently had, we're looking a little bit more thoroughly at the data and those individuals that maybe decline or want to terminate their contract a little bit earlier because they have to sign on so early in their educational career, and then by the time that they complete, they're like, wait a minute, life has changed, things have gone different than maybe what their plan in their head was. And so we are really trying to look at that, and I think that's something we want to bring back to see as well. Is there some alternatives to, do we need to have a rule track? Is that something that is a complete barrier to a lot of students that are wanting to participate specifically in the loan forgiveness program? And are there opportunities to adjust when we start wanting students to maybe apply for these programs a little bit later in their career, when they maybe have a little bit more formalized understanding of where they want to begin their practice? And so we are absolutely aware of that too. And I appreciate the comment, because I think that is something that, we're kind of tricky on how we kind of move forward with some of these, and what we have available to us to change and modify, and what we need to do some additional rule changes for. And we are looking at primary care as well. Primary care has the term has changed a lot since, and so what does that mean to be a primary care as part of the loan forgiveness program? And I think that's something we're also examining, whether or not the primary care piece needs to stay in, or we have another title for it.
Thanks,
So
Jill. Sorry, that's okay. Dr. Hemmings?
Yes, for the non-OHSU SHOE, how are the disciplines that's decided? How is it decided which disciplines to include in that? Or which professions? I say discipline, which professions to include in that?
So this is based on the institution. They submit their application, and they're the ones that they have to submit kind of their curriculum for all the programs or the disciplines that they want to include as a kind of a scholarship. So this is dictated by the institution, not by us.
Is there any guidance that's given from OHA to the institutions as it relates to, in terms of how they go about making determination about which professions to include? Is there any kind of data that drives that decision making on the institution level? Like, how does the institution decide in which programs they want to develop scholarships for? And is there any guidance from OHA as it relates to that? I'm just trying to go back to what was the purpose of the SHOE in the first place. I guess I'm missing that.
I see two other hands up that have been here a little bit longer, so I think I'm going to pass that off to them if you're planning on answering those questions.
Well, I was just going to add, because I know that you are in the mental health field, and when this RFGA went out, it was actually split between primary care and dental that came from our fund. And then because the Behavioral Health Workforce Initiatives team was up and running in a different division, we split out the opportunity and the funding for behavioral health through that initiative. And so I think Terrence is on the call and can speak more to how they might have identified which professions would be funded for behavioral health. This was the first time we funded these schools instead of contracting specifically with the students. And I would say when they applied, and this predates me when they were selected, but it seemed that we were trying to leave it open to the schools to have a broader profession base. And especially you'll see in the community colleges, we really allowed a lot of different types. And I think that's our way of sort of testing the waters of, can we make an impact with these other types of professions that aren't necessarily, you know, our regular MDs and DMDs and this type of thing. So, you know, we were pretty flexible on which types of programs they would be accepted into. And then what we're gonna find out soon is who actually applies, right? So we're kind of testing out at these schools, which students are applying for this, where are they primarily falling under, like which training programs and such. So I would say it was a flexible setting for the schools to really help, for them to really determine which programs they thought needed these funds. And then Mark, you go ahead.
Thanks, Leah. And I want to go back even a little bit further than Leah presented, all of which was accurate, absolutely. And what Jill said, yes. And to emphasize something Leah said, this is the first time that we sent out a request for grant proposal in making these non-OHSU SHOE funds available to institutions and training programs. I'll try to be brief. Where that came from, Dr. Hemmings, you asked, well, what was the purpose of the non-OHSU SHOE? It's a great question. In 2016, the SHOE program had been around for more than 2 years. And as part of an old series of listening sessions in the fall of 2016, the Workforce Committee heard, particularly from Comp Northwest, but some other community partners, we don't think it's fair that only OHSU gets scholarship money. We'd like to have a scholarship program available for other institutions. So that's first of all where that idea of a SHOE-like or non-OHSU SHOE program came from. And then we started with the institutions who had expressed interest in 2017. That was Comp Northwest, Pacific University, and the National University of Natural Medicine. Others we didn't hear from. And then in 2019, the Workforce Committee members said, well, we don't think it's fair that only those who know about it get to participate. We think you need to expand this, democratize, and that's where the request for grant proposal came from procedurally. And then everything that Leah said and Jill said around that it's up to the institutions who they want to make awards to.
Yeah, thank you for that. Well, actually what I meant was SHOE in general, not just the non-OHSU, but I would agree with that. I'm just concerned about how these institutions are actually determining which disciplines or which programs to identify to award scholarships to. And in terms of if there isn't any guidance from OHA, I was just wondering about, factors such as social determinants of health, which has an impact into which professions people choose to go into based on your own personal lived experience as relates to social determinants of health, does impact the professions that people decide to go in, and how that factors in to the determination about, which programs are scholarship eligible and which ones are not. But that's probably a discussion for a much larger audience than we have here today. So.
So this is Terrence, and I behavioral health related programs. So for SHOE-like, this last cycle of applications, it was through an RGP, and we awarded all of the institutions that actually applied for funding. And to be considered for funding, you had to be an eligible training program. And an eligible training program was defined as any program that leads to a healthcare certificate license to get into the workforce, whether it's behavioral health, dental, or primary care. The awards were split up. So the healthcare provider incentive program that Jill and Leah run funded the primary care and the dental programs. On the behavioral health side, I have those contracts, and we awarded 5 different organizations: Chemeketa Community College, for their addiction counselor certification program and also their associate's degree for addiction studies, social services, and direct support professional for their associate's degree as well. Lewis and Clark University, the Mental Health and Addictions Association of Oregon, Pacific University, and Umpqua Community College were the institutions awarded. So it was really dependent on who applied for funds, and there were parameters on like who can receive funds, which communities are prioritized, and that directly came out of House Bill 2949, leading with people of color, tribal communities, LGBT, so on and so forth, that were listed in that bill. So hopefully that provides a little bit of context to the behavioral health side.
Do we have any idea why there weren't more institutions that applied for the non-OHSU SHOE, especially those who have other programs within the health profession that also have a lot of students who are meet the criterias that were listed? Do we know why they didn't apply, or did they apply and just not get approved?
Neelam, do you want to jump in first, and that I could definitely answer?
Yeah, you know, I think we tried to do a lot of outreach, Dr. Hemmings, but I think it was the first time we had issued this request for grant applications to education institutions. So there were definitely a lot of lessons learned. Even on the primary care and dental side, we awarded everyone who applied. And so, you know, I think we just need to, we're looking at it for this biennium, making changes to the request for grant applications process to facilitate, for example, we didn't get any applications from nursing programs. With the exception of, I think, maybe 2 of the community colleges that include some nursing in them. We were expecting more from other institutions. I think it also, unfortunately, was a timing issue. The RFGA was unfortunately released the end of June. We extended the time frame to allow more time for different various education providers to apply, but I think there were just kind of some different factors that we're hoping to address in this next iteration.
Yeah, because I think of institutions like Warner Pacific University that serves a, you know, low socioeconomic, very diverse student body. They have a nursing program as well as the School of Social Work undergraduate program. So I'm surprised to see that, you know, that wasn't on here, you know, and I have to think about, like, why would an institution want to actually have this money, these dollars, right? There has to be a benefit to the institution, not just to the students. And so I'm wondering if, you know, part of the incentives would be, do we get more students to apply if we're able to offer them financial assistance, such as through the scholarship? And I'm just wondering what is the rub there in terms of whether or not how the institution sees this as a benefit to them versus just a benefit to individual students, and who are they trying to attract into their universities and into their institutions. And once again, I'm going back to the systemic issues that exist into who gets into these programs and who does not. So that's just something to think about.
Yeah, I mean, that's a mouthful to think about as well. And I appreciate that feedback, because one of the big barriers for like the wins for this solicitation in particular is that administrative costs were not allowed to be received from the education institutions in this particular solicitation. The stipends piece that you're alluding to is definitely something that could potentially happen as well. On the behavioral health side, we do have a solicitation for tuition assistance and stipends for graduate level behavioral health students. And we did receive feedback from 8 higher education institutions, and we're going to award all 8. And I can provide those names a little bit later. But Leah, I do see your hand up, so feel free to jump in.
I was actually going to say that the same thing about administrative costs, and that is a barrier for smaller training programs that the non-OHSUs of the world. And so, you know, I think that that could be prohibitive for some, because it does take staff time to field the applications, to market the opportunity, to review. Yeah, so I think it's overall that was a barrier that we heard feedback on. And we are thinking about some ideas to retool the Show We Like so that it does actually include some ideas that we've thrown around are, you know, the tuition assistance. So, you know, will we have baseline, but then also having an option for some type of stipend to go along with that, because some of the students may, you know, be having to leave work to go through this program or having to have childcare. And so being able to provide some support in those areas. And then also what we're hearing is that there's maybe not enough educators. And so, you know, could we also include some funding in this opportunity to do some type of educator? I don't know if it would be a bonus or what it would be. And the one thing about the administrative costs is that that's included in our rules. So our state, you know, ORS basically says, you know, it has to be scholarships only. And so we're looking, as we do budget work and programmatic work, we're thinking, how can we also update our rules so that it can reflect a more equitable programming of our incentives too. But Paula, I see your hand is up.
I was just going to follow up on what I was just saying. You know, another social determinants of health, you know, comes to mind for me when I think about students. And also I'm just wondering, you know, if I have to be full-time versus part-time, is there a certain number of credits that I have to be enrolled for? If I have other things going on in my life, a single mom, right? I may not be able to take as many credits as, you know, might be required, even though the funding is there. How do I continue to live and support myself and take care of the rest of my life, other part of my life, while I pursue this degree? You know, those are just real things to think about when we develop these scholarships.
Thank you, Dr. Hemmings, for that perspective. I appreciate that. And thank you all for the rich discussion that we had, the presentations. I realize that we are at time for today. I want to remind everyone that we do have our October 4th special meeting. I want to say, was it 8:30, Mark?
Excuse me, I believe it's 9:30.
9:30. Okay, perfect. All right, so 9:30, and then our next official Healthcare Workforce Committee will be November 8th. And really quickly, I'm just wanted to throw the link in here. The Oregon Rural Health Conference is happening. If you would like to register for that, please do. It's going to be a very great conference this year. So there you go. There's your meetings. Anything else for the good of the order before we wrap it up for today?
I think Paul had his hand up before.
Sorry about that, Paul.
No, that's okay. Let's go ahead and wrap up. Nothing
Okay,
important.
Sorry, Paul, I didn't see your hand up. I apologize for that.
That's okay.
Okay, everyone, thank you so much for being with us today. It was a great meeting, and I look forward to seeing you on October 4th. Have a good day.
Have a good month.
All right. Bye-bye, everyone.
Bye.